remember a little bit the day one, that was yesterday, the TAVI day, and I tried to make a presentation that bridges a common disease, coronary artery disease, with aortic stenosis, and our approach to patients with multiple problems at the same time, which is always a little bit more common than the clinical trials would like us to do, because as you know, every clinical trial of a device, of a valve, usually focuses in patients who mostly have one problem. But these patients are a little rare in our clinical practice because nearly all our patients have multiple problems. So let's see, TAVI and CAD. There's a pathophysiologically a lot of, I would say, synergistic pathophysiology. Why? Because TAVI is in severe aortic stenosis, and severe aortic stenosis is a form of very severe heart, associated with very severe left ventricular hypertrophy, diastolic dysfunction, reduced coronary flow, subendocardial ischemia, and all that, just based on the fact that there is a lot of thick myocardium, and ultimately a reversal of the normal endocardial epicardial blood flow ratio, even at rest. Myocardial remodeling and reverse remodeling after AVR, it's a holy grail. We hope it happens. We don't know how often and how fast it happens. Ultimately, we want to see that happening. Overall, the difficulties that I explained in the pathophysiology of the epicardial flow in and the microvascularization, really, with severe aortic stenosis, impact the indices we may use to assess coronary artery disease in patients with severe AS, and looks like those that are not dependent to vasodilation are a little bit more reliable in this scenario, such as the instantaneous freeway ratio, IFR. So in looking in TAVI and in severe AS studies, you get an impression that over time CAD is going away. This is a two-factor related reality. One is that by treating low-risk patients progressively in the later part of the clinical trial continuum, you have less comorbidities and perhaps less CAD. At the same time, the definition used evolved over the time of the clinical trials. So initially, a lot of attention was paid in the severe AS and not so much in CAD. So any CAD indiscriminately could be marked as such in the case report form and reported. Later on and progressively, we have refined this definition as CAD requiring a previous PCI or bypass. So the reflection of the lower prevalence is also a reflection of this change in a little bit more restrictive definition of the variable of CAD. In looking now of what happens in outcome of patients undergoing TAVI with concomitant CAD, one can say, you know what, how do you do CAD, no CAD? Doesn't seem to be much of a difference here in a meta-analysis of 8,000 patients. But if you pay a little bit more attention, when CAD becomes of a more severe kind with a higher syntax score, all of a sudden it seems to affect mortality pretty significantly. And that's really the CAD that is concerning of us. It's not the non-obstructive CAD or the mild CAD that we're dealing with. How do we evaluate CAD? Even now in the most current guidelines, the CT angiography becomes very strong. And of course, there are two kinds. One is a dedicated coronary CT angiography, and the other is the CT angiography we do before the TAVI in patients with severe AS. And the question is that good enough? The limitation is that because of severe AS, these patients are not given nitroglycerin, and at the same time, there may be a lot of calcification. There may have if adverse effect in imaging of coronaries. Notwithstanding these two limitations, sometimes we do get good images, particularly in the proximal half of the coronary arteries. And if that's the case, that actually may be acceptable based on a clinical study they did at the Cleveland Clinic and is included in the guidelines, provided that we obviously have a good image. So it's not a penalty for accepting it if you happen to get a good image. How often do we do that? In my opinion, it happened in my practice. Actually, it seems to happen about a third or a quarter of the cases due to calcification and absence of nitroglycerin and non-dedicated study. Really, most of the cases were not able to have a clear result. This is the 2025 guidelines that include CCTA, but concern here, pay attention to this, they don't consider the valve CTA, they're considering for the class 2A if you want to do a dedicated coronary CTA. So that's a little bit of a tricky, as I said, is because in those patients you may not give nitroglycerin. So the timing of PCI in patients undergoing TAVI has attracted a lot of attention. PCI before the TAVI was the original aspect, and can we do that? Everything has a pros and cons. The disadvantages is that you commit to some dual antiplatelet therapy. How do you assess reliably all the lesions? We talked about that. The IFR is maybe a little bit better way than the FFR. And the clear benefit, one clear benefit for everybody to remember, you have a free access to the coronaries. You don't have a valve cage interfering right before the coronaries. On the other hand, if you do it after the TAVI, you have another clear advantage, different, which is your patient no longer has severe AS. So you're operating in the coronaries while severe AS has been taken care of. And the obvious disadvantage is that you have to maneuver your catheters through the struts of the valve, of the aortic valve, the new aortic valve, the prosthetic aortic valve, in order to access the coronaries. So that may be technically a little challenging. And obviously depending on the type of valve. Interestingly, this was somewhere, I would say, in the bubble, in the twilight zone. It's just nobody was paying much attention to it until a retrospective study here indicated that all of a sudden patients in the orange bar were doing much better than those in the blue and the gray bar. And what was the orange bar? It was the patients who had a PCI after TAVI, and that sparkled some interest. I mean, are we doing something wrong by doing PCI during TAVI or PCI before the TAVI? And should we just be routinely intervening after the TAVI? In all these cases, you have to remember that the studies are retrospective. So if you look on the left side of the pie chart, you have the explanation already. The orange slice is very small, less than 10% of the patients actually were selected as a good candidates for this approach. So at the end of the day, what the right side bar graph means, it means really nothing that allows us comparison between the bar graphs, just means that the doctors did a good job by selecting those patients carefully. They had a good result. For some reason, the routine was otherwise, was to do stage before, 65%, 25%, they will do it during the procedure, and only 10% after procedure, after careful selection. So obviously, as an outcome of that, well, some other studies were presented, and more of a pilot, I would say, less than 100 patients per group, and indicated that in a year assessment, PCI didn't really seem to do anything. So these guys are saying, you know what, these guys are fighting, you do it before, you do it after. How about if we don't do it at all? And we see later what happens even if we need it. And it looks like in a year's way, we really don't need it. There's more bleeding and nothing really to offer. Well, a bigger study is always helpful in that situation. And it did happen. And again, the similar way, conservative versus upfront PCI in TAVI. And this time, the important factor is that it went out to 5 years. And a lot of people, the results were highly significant in favor of PCI, and many are just always asking, well, what's the difference? One study is this way, the other study that way. That's not the case at all. The studies are very concordant. This study at 1 year is also negative. So you need years to be accrued in order to reap the benefit of the PCI in a stable patient with severe AS. So the benefit is clear after the second year and starts emerging only after the first year. So if the previous study assessed everything at 1 year. So it just wasn't long enough, the follow-up. So it was biologically not possible to reap any benefit at 1 year. You're looking at the 5-year benefit range. And this is due to a trend towards improved mortality, significantly lower myocardial infarction, and significantly lower urgent revascularization. So all of those parameters trending favorably and very concordant towards a benefit at 5 years for performing the PCI. And different study was interested as well into looking at another way. Because while we're doing PCI, before TAVI, after the TAVI, during TAVI, to do it, not to do it, we always have some surgeons in the heart team, and people can say, what, you guys gone crazy about the PCI. Well, how about if we just do the surgery? That's a good answer sometimes. So, what, there's too many discussions about the PCI. You have the valve, you don't have a valve. Just put a couple of bypasses, replace the valve, everybody's happy. None of these discussions left and right. But I must say that I don't know of any study ever done in the combined CABG and AVR. It wasn't done. So it's easier to say, I'm professing, wait till we do the study results. This study was in Canada. In the Canadian system, which is a national health system, highly regulated, only few centers of excellence are allowed, or are not allowed, really assigned to perform these complex procedures. That's how the system is organized per territory. And a very specific number of people is certified and assigned to be performing the PCI and the CABG. It's not like a private system that you can have gazillion surgeons or gazillion interventionalists and some of them low volume and this and that. So everybody seems to be in a well thought of and regulated aspect. Interestingly, the study was halted by the Data Safety and Monitoring Board early because of an overwhelming benefit in one of the, or overwhelming risk in one of the two arms. Well, let's see what those arms are. One is the, I would say, classic control group, CABG and AVR, supposed to be the classic one, the 160 patients. And the other one was the experimental arm to do an FFR-guided PCI plus TAVI and, see what happens. And what happened was that a lot of people died. There was the main outcome was, of course, a complex composite endpoint of mortality, MI, stroke, TVR, valve intervention, bleeding, all of those together, but primarily driven by mortality, as you will see. And interestingly enough, was completely counterintuitive, but what we would think. People were concerned that the arm that is dying is the PCI arm, but apparently it was a surgery. And you can see how consistent the results are. There was a lot of death and a lot of cardiovascular death. There are actually 7 overall deaths, 6 of them cardiovascular versus 0 in the PCI arm. And of course, you have higher bleeding with CABG, higher atrial fibrillation, repeat thoracotomy. I think on the right column, those things are expected. And they're not really part of the major endpoint. On the left side is the major endpoint that is primarily driven by the bypass, and the strokes were very rare, interestingly. So that's why you have to somehow pay attention to that. I'm looking forward to a second study in this arena investigating CABG or AVR in order to better understand the risks of these patients and how we really referring the patients to complex combined surgeries. Is everybody really understanding what's in it versus, kind of have just general thought about it, but not specifically studied. On the other hand, you can see from a registry how this outside the studies and the real world figuring out this situation of TAVI and significant CAD. And you can see over the years, the results are pretty good. Efficacy at 3 years within obstructive and non-obstructive CAD. That by treating the CAD, the doctors in the community seem to be doing pretty well overall, whether they have or not have. But by targeting the main lesions in the proximal vessels. Don't go into crazy with distal lesions. I would not IFR and marginal or a diagonal branch, for example, but I would definitely take care of approximately the proximal circ, proximate RCA, no question about it, before I go ahead later on to perform the TAVI. So the guidelines, what do they tell us? They tell us actually exactly that. The 2020 American guidelines, I think they're up for upgrade, not upgrade, but maybe a renewal later this year. And also last year's, the European guidelines, the class 2 indications for PCI to be considered. Interestingly, there's no class 3 for bypass plus SAVR, but it may come up if a second study is again negative. That's going to be a little bit of a problem for the combined surgery, but we have to really be concerned about these referrals and be very careful about the quality of the surgery in whoever is doing these complex double procedures. Upcoming studies that we're going to see in this arena, there's a lot of interest. The PRO-TAVI trial is a deferral of PCI. I think this was designed a little bit earlier. I think we're probably a little bit beyond that. We know there is some benefit, but anyhow, these investigators are going to try to see if they're deferring the PCI or not. So everybody is getting TAVI, and let's see how this pans out. This is the outcomes that they ultimately have in the, the difference in the non-inferiority of the deferral of patients with PCI, but the more important one is a complete TAVI trial, which is very large. As of now, we're talking about maybe 100, 200, 300 patients. All of a sudden, we're talking about 2,000 patients per group, meaning about 4,000 patients, trying to figure out if complete revascularization up front or an initial medical therapy with subsequent revascularization as needed. Pretty much like the ischemia trial in the coronary arena, stable angina arena, but in patients with AS requiring TAVI. This is what's happening here, and has a median follow-up of about 3.5 years, means that the initial patients followed up to 5 years, and in the towards the end of the study, the patients followed up by 1.5 years. And let's see how that happens. It may give results over the next 1 year, and I think I will definitely be interested. I also foresee that there's going to be a study about surgery. I just don't know from which part of the world, given the unexpected results of the Canadian study that was published in Lancet last year. The TAVI PCI is another aspect of angiography completed vascularization, then TAVI in 45 days, or TAVI versus angiography afterwards. This is pre and post. I think is also designed a little bit before when this topic was hot. I'm not sure this topic is as hot right now. I think everybody kind of believes that they're kind of similar, so it's a little bit of a individual doctor assessment. My preference is to default in the pre-TAVI. I never encountered a patient who really needed such an urgent TAVI. At times, we may temporize the situation by bridge BAV, perform the PCI, and then come back in a few months and do the complete job with the TAVI. This kind of stepwise approach has always worked very well, no matter how complex the patient has been in New York. So in general, indication of revascularization of patient with AS is determined by the symptom status, the severity of the stenosis, the occurring risk, the procedural risk, and the life expectancy. Don't forget about the last one. That's why I always say that I focus only in the proximal areas. I don't think the distal vessels and the branches have anything to offer in this population, that the symptoms are dominated by the proximal CAD and the aortic stenosis, and not so much by some branch disease. Recent evidence suggests that revascularization of the high-grade major arteries is associated with reduction in MI and early revascularization, as well as a trend towards improved survival. And there are a lot of studies of timing and procedural strategies, including TAVI, PCI, as well as surgery in these patients. And I think that the debate will be ongoing, and in anticipation of the American guidelines later within a year. Thanks so much for your attention, and after some questions, maybe we'll go to the break. But one question right there.
Hi, Dimitris Kalapraziotis from Quebec City in Canada. Can you hear me? Yeah. Excellent presentation, excellent meeting. It's a pleasure to be back in Greece. But I must correct you, Dr. Dangas, on the trial that was presented at EuroPCR 2024, and then subsequently published in the Lancet. Actually, there was not a single Canadian patient in that trial.
No.
It's from 18 centers in Europe, yeah, and it suffers from the same problem as the Dedicate trial in Germany, which showed dramatically horrible results for cardiac surgery versus TAVR in a non-industry sponsored trial of TAVR versus CAD G. And the problem was, as in Dedicate, there was some surgeons included in that trial that do 2 AVRs per year, you know, and so the results were horrible because of the reason you mentioned, that everyone is included in this trial. And in Canada, you're not allowed to do TAVI unless there's a surgeon scrubbed in with you, and thus just as you mentioned, all TAVR and CAD G is done by people who do a lot, and we do a lot. And so no center can just do it, you know, a TAVR or CAD G for that matter. So I'm not saying.
So it was a patient, you mean the surgical experience is more responsible for this result or not?
And the trial that you showed where the results were horrible for AVR and CAD G, which is horrible results, 20% mortality.
It was early mortality. Although you saw the curves, it was just so essentially
I'm really
1 month.
Sorry to highlight this, especially here in Greece, my parents' country. There was not a single Canadian patient in that trial.
Well, good to know.
The primary
good news.
author was a fellow who subsequently did his training at McGill, which is in Montreal. But that's
maybe that's a trick. Maybe the subsequent training in order to learn how to do the procedures. But you can see here really the surprising factor is that this 1 year results were dominated by the 1 month results. There's not any progression of the curves. There's just early mortality essentially, operative mortality, quite frankly, rather than anything else. Everything afterwards, the curves are parallel. That's why it's always interesting to see the way the results are accrued. If it was a stepwise, you can talk about maybe a later effect or whatever. But here we're really talking about the technical results. That's why we always say that you have to realize the results in your own center, or in your vicinity, in order to know exactly what's the operating team and how they do and all that.
So
George.
Obviously, there is a great ambiguity on this topic, and probably is related to the age of the population which is enrolled. The mean age is around 80 for TAVR. So in this range of age, probably we have to think on a different way. And also, George, a practical issue is the patients who have already CABG. We have a good number of patients who have been already revascularized in the past. How will you deal with those scenarios?
Well, those are good ones for TAVI because you have extra protection. You know, one of the always difficult scenarios is that in the TAVI, you put a valve that kind of interferes with the coronary access. If the bypasses are open, or at least the lima is open and another graft is open, then all of a sudden the TAVI cage is unrelated with those blood flow, I would say, blood flow origins. So that's good news, unrelated.
What I always find difficult to decide is regarding left main and left main equivalent. I mean, if we are honest, none of these studies evaluate the left main or the left main equivalent in a prospective manner. So on the one hand, if you do the TAVR and you don't deal with the bifurcation, you have to do it afterwards with the valve inside. If you do the left main or left main equivalent as a bifurcation before TAVR and the patient has a few seconds CPR, he will probably never come back without doing emergency TAVR. So I think isn't that a cohort that we should discuss about doing simultaneously, like the typical left main bifurcation, Medina 111, and severe aortic stenosis, simultaneous treatment for this specific subgroup, like a surgeon would do it?
Well, that in those cases, I always consider always do the BAV. So start the procedure with a BAV and then proceed with a left main bifurcation. So they have some, I would say, better blood flow during the procedure, and then we come back a month later or so for the TAVI. That's my approach. The PCI concomitant to TAVI seems to be a bit too complex, particularly if you contemplate that most of these people have calcific left main bifurcation. So you're talking about rotablator and this and that, so that, that might be a bit complex all of a sudden. You have like two major procedures with most of them producing hypotension. It may be a bit too much.
May I ask, in all this discussion about TAVI and coronary artery disease, is there any distinction being made going forward about short balloon expandable valves versus long frame self-expandable valves in terms of choosing which platform to use for patients with significant coronary artery disease?
Oh yeah, of course. In my mind, the valve choice is mostly about the coronaries. We may not really talk about that, but the valves now and the different sizes that they come, they really can accommodate. It's very rare to say that this particular valve, this particular patient is only candidate for this one valve. I think that's now a minority. Maybe initially 20% of people were in this category. I think now maybe it's like less than 5%. So it's mostly about the life management, which is also related with the coronary access. And also the valve manufacturers have acknowledged that they're just increasing the cell size at the level of the coronaries, which is also very helpful. So they too acknowledge that it's really a problem, and they have to accommodate that. It's a fact. It's a reality. You can have an acute MI, you can have additional valve, even if this valve works well, and then later on you're going to put another valve. Then how is that going to be working? So it is really a complicated scenario there, and I know we don't like to maybe openly about it, but it is really in the back of my mind of everyone who selects a TAVI device.
So we have to thank you, George, so much, and we have to close the session. And please enjoy the 15 minutes coffee break.